You can see the image, the screen, Pata?
Yes, madam.
You see a baby there, na?
Yes.
Okay.
Hello, madam. I think all have joined.
Okay. Shall I start?
Okay.
Okay. So, like anybody can ask questions if you are not clear about the things we are discussing here. So, we'll be discussing today about the neonatal life support. You call it as NLS. So, what the Sri Lanka at the moment is practicing is the UK resuscitation guidelines. So, some of these slides I have taken from the NLS, like the workshop we do at the College of Paediatricians. But these are old ones, 2016 slides. But now the newest guideline is there, 2020, I suppose. You can just go to the Google it and see UK Resuscitation Council newborn resuscitation guidelines, right? So they give the newest recommendations and like a algorithm for the resuscitation of a newborn. But now you have to know, you have to have hands-on skills on resuscitation of a newborn. That we will be doing it during the next session, but we will discuss today about the basic algorithm that we have to follow during a resuscitation of a newborn. Now you can see here, there is a newborn here. I hope you all can see. So this one is just born, and you can see some blood stains there, like probably through when the baby came through the vaginal birth canal. So there are some blood all over the baby, and vernix caseosa, you can see the whitish things, and the color of the baby can't comment in this picture though, but you can see baby must be active. There's a good tone. Both upper limbs are in flex posture, and he has opened his mouth, and someone is cutting the umbilical cord. So you can see the clamp. There should be another clamp the other way, the clip, and in between you cut the cord, right? There are some basic things that we have to observe in this baby and examine and do during just after the period, just after birth, right? So, and just I want you to concentrate on the physiology behind the resuscitation of a baby, because you will be able to easily understand when we look at the physiology behind the baby's birth and it related events, right? So you know, antenatally in utero, babies, the whole lung is full of fluid. So you can see here the alveoli and the terminal bronchiole. So all are filled with fluid. So with the first breath, you start evacuating the fluid away from the airways. And here you can see partially emptied the bronchiole, terminal bronchiole, and the alveolus is still full of fluid, and with the maybe with the second breath, or if there is an effective first breath, you can see the whole airway is clear of fluid, right? So just give me 1 minute, I need to look in something. So you can hear me, right? Hello? Can you hear
We
me?
can, madam.
Okay. Okay. So now what the basic thing that would happen just after birth will be the evacuation of fluid from the airways, right? So when that fluid will be absorbed into the surrounding lymphatics, and they will be taken away from the lungs. So before birth, the right side pulmonary circulation pressures are high just because all of these things are full of fluid. There is no blood also not going there because they don't want any blood to perfuse as the ventilation is not happening. But just after birth, when all the fluid is evacuated away from the lungs, the circulation also gets established as the pulmonary resistance drops. Right? So, you can see this baby. This baby is nicely crying, active. All the four limbs are in the flex posture with a good tone, and color is pink, and he is crying. Means the airway is definitely patent. If the baby is crying, you are happy that you know the airway is patent, right? And so the color is also good. What can you do with this baby? So just after birth, if you see a baby like this crying loudly with pink lips and the peripheries are also partially getting pink with time, otherwise it may be a bit dusky because of hypothermia, and the tone is very good, nicely flexed posture. So what do you want to do with this child? Anyone? So code
Keep
is
the baby warm.
yes, good. So you can keep the baby warm by wrapping with covering with the 1 or 2 dry towels and a cap also, and then
Then start breastfeeding.
yes, good. So you can hand over the baby to the mother. You can initiate breastfeeding within first 30 minutes to 1 hour, and you can hand over the baby to the mother. So that's a happy place, right? You don't have to do anything. You just might auscultate the lungs and look at the anus because you don't want to miss it, and the spine also. Then you auscultate for the heart sounds. If in any significant cardiac murmurs, just after birth, you might look at the cleft palate and the anus, right? Those are the basic things we just after birth usually a pediatric HO would look into. Palate, back, and the anus, right? And any cardiac murmurs. But even if it is a murmur, if there is a murmur, you don't have to worry. You can just wait and see observe with saturations and everything, right? But for a newborn who is born like so here they say stimuli for the first breath. Just for your knowledge, when there is cord obstruction and temperature changes of the baby and the physical stimulation, like we rub the baby and stimulate. So when you do all these things and when the cord obstruction is there will be carbon dioxide accumulating inside the baby's body because you can't put the carbon dioxide and the metabolized things away from the baby's body because the placenta circulation is being obstructed. So then the carbon dioxide will stimulate the spontaneous respiration, and that will be a stimuli for the first breath. And the temperature also changes. In utero, high temperature, maternal body temperature will be there. When you come out, there will be low temperatures around, and the baby will go baby is more prone to hypothermia. So with this temperature change also, it acts as a stimuli for the first breath. And then we anyway do the physical stimulation. You rub the baby while wiping the baby with the dry towel. You rub his back gently and stimulate him. So then all these things will stimulate the first breath. So with that, babies will breathe. So that's what the basic thing happens just after birth in a normal newborn. So with the first breath, I told you, there will be fluid pushing away from the alveoli and establish the resting lung volume. And now you can see this X-ray. I just want you to look at the images just to have something into your head. So this at 0 seconds, just at birth X-ray, you see there is fluid filled in the lung completely. And 0.3 seconds, maybe just after a single breath, right side lung is getting aerated. Air you can see in black color. And now the left lung is also aerated, right? You can see gradually the lung aeration occurs. So that's what we want to do actually. So the response to hypoxia, I just want you to have some idea about a graph I will be showing in a later slide. So I will be discussing what happens just after birth. So then you will be able to remember it easily in a logical manner. Right? So now they have done these animal experiments. You don't have to remember these things using a fetal lamb. What they have done is they have delivered the fetal lamb, fetus, and just with the delivery, without letting him to breathe, they have just immersed the fetus's head inside the water. So now it's like the baby is again back into the water. So he can't breathe, and they have then observed the breathing changes, any breathing patterns of the fetus, and the level of consciousness, blood pressure, heart rate, and the arterial oxygen and carbon dioxide concentrations they have measured. So using this experiment only, they have come into conclusions what happens inside a fetus, right? So now, when here you can see when a fetus, suppose now you don't have to put a fetus into the water. Suppose someone is strangulating your neck, so you will not be able to breathe. So initial part, you might struggle to breathe, and there will be more rapid tries for breathing. So there will be rapid attempts for breathing, but still as the airway is being obstructed, your arterial oxygen saturation will drastically drop down. Right? You can see the PaO2 drops to a 0 at what point, and it remains in 0. So now during the next part, what happens? Now the baby is being strangulated, or the fetus can't breathe. Now still it's inside the water. Initial first rapid attempts are there. After that, there will be a period of apnea. You call it primary apnea, right? You just have to have some knowledge. I don't want you to remember each and everything. If you remember these first few words, that would be enough, right? So there will be a part of primary apnea. And now the one advantage is babies, they have a thing called agonal gasping breaths. That means just before death. Agonal means just before death. They are capable of having some spinal level stimulation of spinal reflex stimulation of their breathing. So they are like not the normal pattern of breathing. They will be deep but slow breaths. They are being more spaced. So you call it just before death, you can see they are gasping. They are called gasping breaths. So now, after a period of first primary apnea period, there will be gasping breaths coming. They will be regular. They are not happening regularly, just unlike the breaths which is being stimulated by the brain centers. And now they will be deep. They are trying to take some oxygen somehow inside. So that's what the gasping breaths are here. After that period of gasping breath, again the baby will go into a period of apnea. You call it secondary or terminal apnea. So once a baby goes into the terminal apnea, you won't be able to take the baby back without intensive resuscitation, right? So we'll be discussing next what do we have to do during each and every period when we discuss the resuscitation part. So have some idea what happens just after birth if the baby is not allowed to breathe, right? And so there will be primary apnea, and now the gasping breath comes. Even if you don't allow the fetus to breathe at this point also, they will go into terminal apnea, and still no attempts of resuscitation, they will die here, right? That's the normal physiology behind what you have to do. Whatever the actions we have to do, we have to take following birth of a baby, right? So I don't say like every baby will not do this thing, right? Most of the babies, you don't have to do anything. They will breathe normally, like the baby I showed before. So color, tone, breathing, and heart rate, everything will be normal. You just have to dry the baby, cover it up, and hand over to the mother for initiation of breastfeeding. But maybe a percentage of babies, like maybe 5 to 10%, will need resuscitation, some support during the birth. But if you provided the support, outcome is much better because the babies are born for survival, right? If you can support somehow, they will survive. So outcome is much better, right? Even most of that proportion, like I told you, 5 to 10%, maybe maximum 20% will need some respiratory support. So out of that, even cardiac support will be needed only by a 1%, less than 1% babies. That means you just have to keep the airway open, most of the babies, they will recover. And some babies, you might have to go for some respiratory support additionally. Or even less than 1% of babies might need cardiac resuscitation, right? So that's why if you know what to do sequentially in an orderly manner, you can save a lot of number of babies, right? So just remember these things. Then we will be discussing what happens through each and every scenario here, right? So this is the graph. I don't want you to remember anything. So during these periods, what happens? So, arterial oxygen saturation will remain zero unless the baby has been resuscitated or supported at some point here. And the carbon dioxide will be continuously accumulating because you are not taking any oxygen in or putting any carbon dioxide out, right? In between, so this is the part where your heart rate is being graphed. And during this initial rapid attempts for breathing, it's a compensatory. Breathing also tries to compensate. And the heart rate will also try to compensate by just putting some effort on tachycardia. So there will be initial tachycardia. And failing that compensatory effort, the heart rate will rapidly drop. During primary apnea, there will be some heart rate maintenance just to maintain the circulation for vital organs, such as the brain and the liver. So there will be somewhere around 60 to 70 heart rate remaining throughout the primary apnea. And then comes your gasping breathing. Still the heart rate will be maintained just for the circulation of vital organs. They will shut down the other unnecessary places where the skin and the gut, they will shut down the circulation and will maintain the this part, right? So now this is for the compensatory maintenance of vital organ circulation. But just even if you fail to resuscitate the baby just after gasping breaths, towards the terminal apnea, there will be established bradycardia and cardiac arrest at the end. So that's why I told you, if you didn't support even here during the terminal apnea, the baby will die, right? So I hope you have some idea about what happens. So the acids also they have shown here. Just like the carbon dioxide, you can see acid accumulation also here. And your blood pressure follows the same pattern of heart rate. So initially compensatory blood pressure rise, followed by gradual drop, maintenance for vital circulation here. And during the terminal apnea, just as the heart rate, it will be dropping. So I don't want you to remember any of these. Just have some idea what happens after birth if the baby is not allowed to breathe, because That's what each and every place you will have to support the babies, and depending on that, you will see the picking up of vitals, right? Okay. So now, just here, there is a baby here. Now there is this baby who is having some difficulty in breathing, but it's a distress. Rapid attempts for breathing is there. If you kept the airway open here, that would be enough. Baby will breathe continuously and this will gradually settle, right? So here what happens, this is the primary apnea. Here also, if you keep the airway open, you have to keep the baby dry and cover always. That's the first step. So you dry and cover the baby, keep the airway open. Then baby will go into gasping breaths. When the baby takes gasping breaths, there will be some oxygen going into the baby and the breathing will pick up. Right? So no worries, just opening the airway. Here even opening the airway, drying up and covering the baby and opening the airway would be enough. Right? But when it comes to here, you can see even if you open the airway, sometimes the heart rate might remain low because now there is excessive acid, carbon dioxide, and even if you keep the airway open, there is no attempts for breathing. Whatever the time you wait and see, still there will be no attempts for breathing. Right? Then you have to definitely support with airway and breathing as well as sometimes with circulation. So that will be discussed in the slides to come, right? So here these are the places you have to remember what we told you about. So we'll have a look at the resuscitation part of a newborn baby at birth, right? So I hope you will remember something from the previous graph and we'll be discussing it here. So now, so this is a logical approach. I told you it's sequential. You have to do the things or in an orderly manner. If you skip and just jump into the somewhere at the end part, the resuscitation will not be successful. Why? So I'm just asking, in a baby and an adult. So suppose a baby is collapsed and also an adult is collapsed. So how do you start resuscitating the adult and the baby separately? Can one of you tell? How do you?
Adults with the chest compressions and in babies, madam, with the inflation breaths.
Yes, good, right? So adults, it is mainly the cardiac in origin. The arrest is mainly cardiac in origin and you have to start with cardiac compressions, right? So if you see an adult collapse by the roadside, you always start with chest compressions first. But compared to that, the babies, mainly the arrest is of respiratory in origin. So hypoxia, babies will go into respiratory arrest first and they will go into hypoxia leading to cardiac arrest because their heart is, unless the baby is having a significant congenital cardiac condition, that is a very small amount, I mean even less than 0.01% from the population, right? So all the other babies have a healthy heart with a good amount of glycogen stores. Heart can pump as far as the heart gets enough oxygen, right? So the baby's arrest is of respiratory origin, right? So that's why we have to start always with the airway and continue with the sequential manner. Okay, right. So now we have to think of what you are now. You may be a house officer or a pediatric house officer at any time, or maybe a MOPBU or MONICU, whatever it is. You have to get ready before that's the resuscitation after birth means you anticipate the worst and you have to get ready. Otherwise, now the baby doesn't cry. You go until now, suppose there is a delivery. You go, you don't have any worries. You don't anticipate anything bad to happen. You think the baby will cry and you don't get ready with anything. But unfortunately, you don't know the in utero condition of the baby, although they say the CTG is normal and the scans are normal. Some babies might go into peripartum cardiac arrest even, right? So you can't explain most of the things. So when you go there, the baby didn't cry. And now you are in trouble because you have not got ready with anything. So that's why we say you have to always anticipate and get ready with all the equipments needed. So this slides gives you a set of, I won't be able to give these slides to you because this is from the maybe you will be maybe screen recording or whatever the pictures you can take, but I mean the slides I will not be able to hand it over to you because this is from the pediatric college, right? So I'm just showing you all this because you have to have some idea. So now but the things we have to do before a delivery is shown here. So once you are being informed that you have to go for a delivery, so most of the time they will tell there is a term baby or a preterm baby, they will tell is to be delivered at this moment. Maybe sometimes it may be an emergency delivery, prolonged labor. From the labor room, they might be taking the mother to the emergency cesarean section, right? So something like that. So then whatever it is, whatever the scenario, you have to do this set of things, right? So you have to introduce yourself to the mother and the obstetric staff. When you go there, not like an alien. You can't just behave like an alien and order the people. You have to first tell that I am the pediatric HO who will be looking after the baby after the delivery, right? So to the mother also you have to tell. And antenatal counseling, you can't go and do it during the labor room stay or the section, right? Antenatal counseling you must have seen. So the complicated deliveries, obstetric team, they refer to us. We go much ahead the delivery, maybe a few days ahead the delivery, we go and talk to the mother and tell the possible complications and what our plan is to go ahead following the delivery. So that you can't do here in the labor room. You just have to introduce yourself to the mom and the obstetric staff. And then first thing you have to prevent is the hypothermia, even if it is a term baby or a preterm baby. Hypothermia, you can't forget, right? If you make the baby hypothermic, then it will lead to another set of sequelae that will be problematic and even can end up in death. So that you have to prevent. That's why all these things. So you have to switch off the AC and the fan wherever the place where you are going to resuscitate the baby. And then you have to close the windows. If there are running air currents, you have to close the windows and turn on the heater. So you might have a resuscitator with a heater or a radiant warmer, whatever the resuscitating place, you have to make it activated, and you must have seen the resuscitators or the radiant warmer, so you have to switch it on. Then the oxygen supply, either from the wall or the cylinder, you have to turn on and see whether the oxygen is there, right? Sometimes the cylinder is empty when you attempt resuscitation of the baby. That's why beforehand you have to look all these things. And then you to check whatever the things you can't touch after putting gloves. So the other thing that should come here is the sucker machine, right? You have to check the sucker machine, whether it is functioning, and see whether the nurses or somebody supporter have attached a wide bore sucker tube to the end of the sucker machine's supply, right? So those are the things before gloves. So switch off the AC, close windows, turn on the radiant warmer and the oxygen supply, look at and check it whether they are enough oxygen, and also the sucker, right? After that, only you go and wash your hands. So up to the elbows, you remove all these watches and whatever the things you are wearing. So you have to wash your hands from elbow downwards according to the hand washing technique, right? Then that is for infection prevention. Then you wear double pair of gloves, and then only you will check the equipment that you are going to use during the resuscitation, right? So check the equipment, start the clock. So once the baby is born, only you have to start the clock, right? So here, what are the equipments you need for resuscitation? Always remember in the sequence of A, B, C, right? So you see here, the radiant warmer, you can switch it off, on, and also there is this oxygen and air supply. So this is a new kind of a warmer with the oxygen blender here. And the stethoscope you can see there, and the dry towels. So for the prevention of hypothermia, so right, dry, clean towels are there. And the sucker machine is here, so you must have checked it before. So now after putting 2 pairs of gloves, you have to go and check the other fine equipments you are going to use on the. One thing is so remember according to the ABC pattern. So airway wise, what are the things you need? Can any of you, like, if you don't want to talk, you can put it into the chat, or else you can talk to. So you can talk to me. So what are the things airway, for the airway you need?
Airway adjuncts, madam.
Yes, what are the airway adjuncts?
Oropharyngeal airways.
Starting from, yes. Somebody else?
Laryngeal mask airway.
Good. And so according to the order you remember, so if you want to ambu ventilate the baby as the first step, you might need the ambu bag and the face mask, right? So usually 3 sizes of face mask we keep. And the ambu bag, you have to check whether it is working. So we, during the practical sessions, we'll be talking what is the, how to check the ambu bag. So there are 2 valves. One is the pop-up valve and the fish mouth valve, right? So we'll be discussing how to check the ambu bag there. And those 2 valves you have to check separately. And then you should have 3 sizes of mask. So maybe 0, 1 and 00, depending on the very preterm babies, we might use 00, but for a preterm one, just moderate marginal one, you might use the 0 and 1 for a term baby, right? Like that. So different sizes of mask, 3 different sizes you have to have. So because you don't know the size of the baby, right? So then your airway junks, as she said, oropharyngeal airways, 3 different sizes usually we keep with us. And laryngeal mask airways as maybe a plan B, failing ventilation we might need, right? And also the tubes, ET tubes. In the worst scenario, you might have to intubate the baby. Then you have to have a laryngoscope. Usually we use the straight blade laryngoscope, right? Just we'll see whether you have the pictures of these things. No. Right? So the straight blade laryngoscope we will see during our practical session, and you have to check it and see whether the bulb is loose. Sometimes it might go into the baby's airway. If it is loose, and might get disconnected, right? So otherwise, and you have to on it and see whether the light is working, right? So that is the laryngoscope, and you have to have 3 sizes of ET tubes. So how to, you have any idea how to size the ET tubes in a term baby or a preterm baby? Or as a bigger child, how would you calculate the size of the ET? Any idea?
Age plus 4 divided by 4. There's an equation, madam.
Yes, there's an equation called age divided by 4 plus 4 for babies above 1 year, right? For infants, so age divided by 4 plus 4. Right? For infants less than 1 year and newborns, neonates, you can't use that equation. So roughly we have the guide. Term babies, we might use the size 3.5 and 4. Right? Millimeters internal diameter I'm talking about. So 3.5 millimeters to 4. And maybe a small IUGR baby, you might have to use the size 3. But moderately preterm one, marginal one, you might use the size 3. So you take it according to their body weight actually. So if it is less than 1 kilo baby, you might have to use this 2 and 2.5, right? 1 to 1.5 kilos, you might have to use 2.5 or 3. And about 2 kilos, you will be able to use 2 and not 2, 3.5 and the 4 sizes, right? So that's by experience you usually use. For the very extremely preterm ones only we use the size 2, that is rarely being used. Otherwise, most of the preterm babies are being managed with 2.5, right? So then 3 sizes you have to have the ET tubes. Depending on the gestation and the estimated fetal weight, you will be able to. So somewhere around 600 grams baby, you might have to put a size 2 tube. Right, so then you have to have size 2 and 2.5 tubes. So 2 is the minimum one which is available, right? So now the these things for the airway. Sucker machine we already have checked, and then breathing we oxygen already have looked at, and then you go for the circulation. So circulation, what are the things? I told you circulatory support is being needed only a very small fraction of babies, maybe less than 1%, right? Still you have to get ready towards the worst scenario. That's why, so anticipation and getting ready. So then you have to have some, first thing is cardiac compression. So that is being done with your hand. So you don't need any equipment. But then the saturation monitor should be there. And also the stethoscope should be there. And then the cardiac drugs. Any idea what are the drugs you might need?
Adrenaline.
Yes. So you, as for cardiac drugs, you might need adrenaline and the fluid boluses, right? Fluid boluses you might have to have with you. So that will be normal saline, 10 ml per kg boluses. IV adrenaline, 1 in 10,000. The dose is 0.2 ml per kg. Huh? Yes, I will be checking it and let you know in later part. So 1 in 10,000 intravenous when you are giving, you have to dilute it, right? We will be talking the doses and how to dilute it. So we have the vial 1 in 1,000, 1 milliliter. Vial is there, adrenaline. So you have to dilute it 10 times to make 1 in 10,000. In 10 cc syringe, you take that 1 ml and you dilute with either normal saline or distilled water up to 10 times. So that makes a 1 in 10,000 solution. From that one, you take 0.2 ml per kg. So that is the newest dose, right? So that is adrenaline, and normal saline 10 ml per kg boluses should be there. And really you might need to manage hypoglycemia, 10% dextrose, right? So those are the drugs for cardiac. And so here's the equipment clock. I said initially we have to have the clock. Mostly it is being inbuilt now with the radiant warmers. They get the clock. And APGA recorder is also there. So that you have to clock you on, switch on it once the baby is born, just for your APGA recording purposes, right? So at 1 minute and 5 minutes, 10 minutes, you have to record the APGA. Right, so the gas supply, warm dry towels, we talk, plastic bags for preterm babies, we'll talk later. And firm stable surface for the resuscitation, usually the resuscitator will have it. Ambu bag with blow-off valve and or the neopuff, we'll see a neopuff there in the skills lab, we'll have a look at. So that is something similar to ambu bag, but used for very preterm babies, right? Not very preterm babies. Face mask and the tracheal tubes, good airways means the oropharyngeal airway, laryngoscope which should be functioning, white bore catheter and a sucker, stethoscope, drugs I told you, right? Those are the things that we need to have. So after that, always I told you this is the first step of resuscitation of a baby. So dry and cover the baby. Now suppose the baby is born, you have talked to the mother, you have got ready with everything. Now you have wore 2 pair of gloves and you have checked all the equipment with the first pair. And once the baby is born, you switch on the clock and you remove your first pair of gloves, right? So then only you resuscitate the baby with the new sterile pair which is underneath. So you have to dry and cover the baby. While drying, you can gently rub the back of the baby and stimulate, right? Then you have to assess the situation. So there we will be talking about what are the things that we should assess. And then you have to look at the airway, breathing, circulation, right? Chest compressions, and then followed by drugs. So this is the orderly, that the sequence I was talking to you from the beginning, right? So I told you babies are very small and wet. They are more prone to lose heat and go into hypothermia. That's why dry and cover comes first, right? So you dry with 1 warm towel while stimulating, and that towel will get wet. So you have to discard it and take another towel and cover the baby up. And if there is a cap, you have to put the cap as well. Then you have to look at the chest. That's the place, only place you might not cover with the towel. Head you have to definitely, because it's the major place where the heat will be lost. And then you cover the rest of the baby except for the chest, because you want to observe for chest movements. Earlier, this kind of painful stimulations we have used, right? But now what we do is gently do it. Otherwise, babies will remember now that their remembrance of pain we have not studied at all. So that's not a good thing to induce pain just after birth. So gently rub the back and stimulate. That's the way that they do recommend, right? So the initial actions I told you: start the clock, dry the baby, and assess. Assess and see whether the baby is bad. If the baby is very bad, you might ask somebody to call for help, inform a senior then and there, right? Don't wait. So then you have initial assessment. You have to look at these 4 things. And in between, so whenever you reassess the baby, these 4 you have to remember: color, tone, breathing, and heart rate. So color can be anything if the baby is pink. Right? Sometimes the babies may be blue, and sometimes they may be pale. Right? Blue and pale both need support. Tone, babies will be floppy, flat, without any movement, or sometimes they will be nice flexed posture with moving limbs with a good tone. So those kind of babies you don't have to do anything. But flaccid, flat babies you will have to support. And breathing means babies might be crying loudly. You know they are waist straightened and breathing is fine. Then you don't have to do anything. But if the baby is not breathing, you might not see any chest expansion. Right? Then he needs support. And the heart rate, always you have to assess using the stethoscope. Or the other option will be the saturation monitors. But don't expect here in Sri Lanka now we are actually deteriorating in terms of health. So you will not have saturation monitors when you are going to resuscitate babies, right? So stethoscope, no pulse palpations, no carotid palpation. It should be stethoscope always. Or else the saturation monitor with the pulse rate, right? So these are the 4 things you have to. This is not a universal mnemonic, but you can remember it as CTBH, right? You can't write it in your exam papers as a mnemonic. It's not a recommended mnemonic. Right now, this is a baby. So few scenarios. Now you have this baby. This baby is blue and initially blue with a good tone and breathing regularly. And the heart rate was more than 100, right? It's like you can listen to, you have to get used to the rate of, the more than 100 rate will be like that, right? So the less than 100, you can feel like very slow heart rate. So if those 2 you can identify through the stethoscope, that will be enough. So this kind of baby, good tone, breathing regularly, heart rate is definitely more than 100. And this blue color gradually turning into pink when the baby breathes. So this kind of baby, you just deliver onto the mother's chest, right? Immediate skin to skin care, you call it, because the temperature also will be preserved when the baby is on mother's chest in between the breast, right? And then you cover you initially dry with another towel and discard it and cover with another towel and a cap. So this kind of baby, this is the best way to keep, right? Immediate skin to skin care. It has its own advantages. If you are interested, you can read, except for this temperature regulation, right? So now this baby having blue color, moderate tone, breathing inadequately. There are some breaths, but they are not regular, right? And slow heart rate, less than 100. So what can you do? So where can this baby be in that graph I showed you? That graph I showed you, there were a few places. Now this baby is breathing inadequately. Slow on and off breaths are there, right? So where can this baby be? Is it the first phase of rapid breathing? Is it the primary apnea? Yes. So good. So this may be gasping type of breathing, right? Irregular, on and off, deep breaths. So maybe gasping. I told you if the baby is gasping or having some effort of breathing, just dry and cover always comes first. And then you can open the airway, right? And reassess. So airway opening maneuver in newborns is called neutral positioning, right? We'll be practicing hands-on skills on how to keep a baby on the neutral position when we do the practical part. So you have to keep the baby in the neutral position and open the airway, and you can again reassess and see color tone, breathing, heart rate. So just by opening the airway, when they take breaths inadequately, when you open the airway, there will be good oxygen going in, and the baby's color, tone, and the heart rate, everything will pick up. So first to pick up will be the heart rate, right? It's the very first thing to pick up. Once you open the airway, immediately your heart rate will be increasing. You can see it, right? Then only your color and the tone will improve. So failing that, even if you open the airway, still if there are no good breathing attempts, you might have to go for inflation rates, right? So this may be blue or pale, floppy, flat, no tone, and not breathing, nothing at all. So heart rate, before talking about heart rate, maybe there is slow heart rate, they say, right? Below 100. Suppose now it is below 100, but it is around 60, right? Baby is not breathing. Where this baby can be in that chart?
Terminal.
Yes. So the baby, if there is a very low heart rate, maybe 20, 40, baby can be even in terminal apnea. Even with the 60, you can have a baby in terminal apnea. Anywhere else, this baby can be blue or pale baby, floppy, not breathing, and heart rate slow. Not breathing. Anywhere else, this baby can be in that graph?
Primary apnea.
Yes. So even in primary apnea, this baby can be, right? We don't know. So one way to know is maybe to interpret the heart rate. So, but still, both times the heart rate will be less than 100, right? But during primary apnea, there will be some 60 to 80 heart rate sometimes, but you can't exactly tell that for sure, right? So then this baby can be either primary apnea or terminal apnea. So then you have to do things and see, then only retrospectively you can diagnose where this baby had been. Right? So now you have to again dry and cover. That's the first place. And you have to open the airway definitely. Right? If it is primary apnea, when you open the airway, sometimes baby might take a gasping breath. Right? So because the baby was in primary apnea, when you open the airway, there will be a gasping breath. So then oxygen will go in and you don't have to do anything. Heart rate will suddenly pick it up. Right? So then you can just keep the airway open and keep the baby warm and observe, right? Reassess and see. But sometimes, even if you open the airway, there is no breathing attempts. Now the baby can be either early phase of primary apnea, still not going into gasping breaths, or else terminal apnea. Still you can't wait, right? You can't wait just opening the airway, you can't wait for breathing. So you have to definitely start inflation rates wherever the baby is, right? So now you give the inflation rates, again reassess. What you have to remember during neonatal resuscitation is first thing, dry and cover comes first, whatever it is, right? Even a blue, nothing, just maybe a baby like a dead one, still you have to dry and cover first. Then you open the airway, and depending on the breathing effort, you might have to go for inflation rates. And following that, again, when you do something, you have to reassess always, right? In between each and every step, dry and cover and opening the airway, still reassess color tone, breathing, heart rate. And if it is not responding, only you go for inflation rates. Again, reassess, right? Then, depending on these reassess findings of the reassessment, you will decide next step, right? That's how you go following birth. So these are some, so you know, the an unconscious baby airway obstruction is usually due to loss of pharyngeal tone, So they are floppy. Their pharyngeal tone, muscle tone is lost, and the tongue will fall back. So that is the commonest thing for a airway obstruction. That's why when you keep the baby on the neutral position, tongue will be pushed out. Then you can open the airway, right? Foreign materials are very unlikely unless it is an instance like thick meconium aspiration or something, right? So that's why we tell there is no place for suctioning. Even during meconium aspiration, you don't suck out the babies at first step, right? So never suck a crying baby. You don't have to, because you know the airway is open. If a baby is crying, you are happy, right? Suction does not clear alveolar fluid, you know. So lungs are like very easily prone to collapse. So if you suck out, you give further negative pressure to the airway. You suck the whole of the air and everything out, and the lungs will get collapsed. So you don't suck a baby at first point, even on meconium aspiration, no sucking. And crying baby, you don't have to at all, right? And it will even stimulate vagus nerve, and lead to bradycardia, right? You can see even in ICU babies, when the nurses are sucking for a long time, sometimes they go into bradycardia and cardiac arrest, right? That's why suctioning is not recommended at first place. So airway and breathing, we are going to discuss few maneuvers here. So I told you there is a thing called neutral position that will keep the jaw up and the tongue pushed away from the tongue, dragged away from the airway, right? So commonest cause of airway obstruction is tongue falling back due to loss of pharyngeal tone. Now you want to take the tongue out. So that's why we recommend the neutral position for newborns. But adult children, you know, any word, like any position you call it during the advanced pediatric life support? Anybody know the position the adult children are kept? Older children?
Hyperextended.
Hyper is not recommended.
Extended.
It should be midway. So you call it. So in infants and baby newborns, you call it neutral, and those are sniffing position, right? Sniff, you know, like the dogs, you ඉවල්ලනවට තමයි sniffing කියන්නේ, right? So you ඉවල්ලලා බලන එකට නහය උස්සලා. So that is the position called sniffing, SNIFFING. Sniffing position in big children, right? Above 1 year. And newborns and infants, you call it neutral position, but it is slightly different from baby, the big children, right? So children, compared to the children, babies, occiput is bigger. Infants and newborns, occiput is bigger. So if you extend further, the airway will get collapsed because the occiput is big. So you don't extend their head, you just keep on the neutral position, right? I'll be showing what is neutral position here. Yes. So see, this is the neutral position. So now you can see the occiput is bigger. The head is more prone to get flexed towards the forward side, right? Now you can see this is flexed. So you want to slightly extend, right? This is the next picture shows how to do the extension, slight extension only. If you extend more, right? Now the airway will again get collapsed because the airway is more anterior. Larynx is more anterior in newborns compared to children, and the occiput is bigger. So no hyperextension, even in children, no hyperextension, the airway again get collapsed, and no flexion like this. Again, the tongue will fall back and the airway also gets collapsed. So correct technique should be to slightly extend and keep this. Can you see this? A line going through the tragus here should be parallel to the floor, right? Or the ceiling. A line going through the tragus should be parallel to the floor or the ceiling. And a line going perpendicular to the tragus should be perpendicular to the floor, right? Line going through the tragus it here should be perpendicular to the floor, going through the tragus to the corner of the mouth, right? Corner of the eyes. So a line connecting the tragus and the corner of the eyes should be perpendicular to the floor, right? That's the neutral position you called it. No hyperextension, no flexion. It should be somewhere midway. You can see here, it's the nice neutral position they have kept, right? If you imagine now the tragus is somewhere here, the line going through the tragus will be parallel to the floor and the ceiling, and a line connecting the ear, like tragus, upper part of the tragus and the corner of the eye will be perpendicular. So that is called neutral position, right? So you should know how to keep a baby in the neutral position, and that would be enough for most of the babies, right? So then you can, in case if you have to give breaths, you can keep the baby in the neutral position. At the same time, you can hold the mask like this, right? So failing neutral position only, you have to go for jaw thrust. Suppose a baby who didn't cry at birth, now when you put on neutral position, color tone, breathing, heart rate improves. Then you don't have to go for jaw thrust. But in case still the color tone, breathing, heart rate doesn't improve, you are not sure whether the airway is open. So then additional maneuvers for airway opening you have to go for. So that is called jaw thrust. Right? This is the way you have to give the jaw thrust. This is quite a big baby. Don't mind. Just the same as a newborn, you have to give the jaw thrust like this. Jaw thrust means you put your 2 fingers to the back of the angle of the mandible and push it up. Right? It's this movement. You put your 2 fingers to the angle of the mandible, behind the angle of the mandible, right? Somewhere here. And you push the jaw up. Then with the tongue is attached to the posterior part here somewhere inside. So when you push the jaw up, tongue will also come out with that. So it will relieve the airway obstruction by the tongue, right? So that's what you have to do. Then again you can consider, after giving jaw thrust, you can again reassess the baby and see color tone, breathing and heart rate. Right? Following that, if they are not improving only, you have to go for inflation rates. Right? So the inflation rates you have to give with the bag and mask. So correct size mask, how to select it, you should know. And the bag we have already checked, and how to connect it, and how to give the bag and mask ventilation, you should know. And always in term babies, you have to start with air. Preterm babies, you might start with 30% FiO2, but term babies always with air. Right? So the inflation rates for 5 this is wrong, 5 inflation rates, each have to be sustained for 2 to 3 seconds. That means you have to inflate the lungs. Means you have to put the fluid inside the lungs, push it away from the alveoli to the lymphatics. So that's your aim. So you give inflation rates with the bag and the mask. So we'll practice it during the practical session, but you you have to give for a longer period, sustain for 2 to 3 seconds, and you have to give nearly 30 centimeter water pressure. That means deep pressures you have to give only for inflation rates. Once for an inflated lung, if you give high pressure breaths, definitely it will go into pneumothorax and NALS, right? So only for the inflation, to push the water away, only you have to give high pressure. After that, ventilation breaths will be low pressure, short breaths, right? So that's how you have to count it when you are giving it. We'll be practicing it during the session. But again, counting will be, you have to give over 2 to 3 seconds. So you count it as 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. That's how you have to give the 5 inflation rates. And you will be pushing it through and through the ambu bag, right? Not like halfway through. because you want to give a 30 centimeter water pressure. So in a normal 500 milliliter amber bag, you will be providing when you push through and through. The walls kissing each other, when you throw in that way, it will be around 30 centimeter water pressure. So that's to give inflation rates. Right? Again, after a set of five inflation rates, you have to assess color, tone, breathing, and heart rate. Here, when you give breaths, when you give inflation rates or ventilation rates, you have to expect something more while giving the breaths. You have to observe it additional to these four. Right? That means the chest expansion. So your expectation is to give a good chest expansion. Maybe during the first breath, even in the airway, you might not get a good chest expansion because all it is fluid inside. But with the consecutive breaths, you will see good chest expansion. So always when you give the breath, at the same time, you have to observe the baby's chest. That's why I told you don't cover only the baby's chest during resuscitation, right? So then only you assess when you give 5 inflation breaths. While giving you observe for chest expansion. If you get a good chest expansion, you assess the color, tone, breathing, and heart rate. If you don't get a good chest expansion, you will have to again look into the way you are holding the airway, either jaw thrust or the neutral position and the mask, whether they are anemic. And then again, you will have to repeat the inflation rates until the lungs get expanded. So until you see chest expansion, you have to give inflation rates. So 2 cycles recommended. Failing that only, you have to go for intubation, right? Give inflation rates, then reassess what do you hope to find. I told you the first is to pick up will be the heart rate, right? First vital sign to pick up will be the heart rate, then only your color and the tone will improve. So you, while giving inflation rates, you always observe for chest expansion. After that, when you assess color, tone, breathing, heart rate, you see a heart rate picking up earlier than the other signs. So I told you how will you assess the heart rate? Yes, stethoscope pulse oximetry. Heart rate response, you can assume the lungs have been inflated. If the heart rate picks up, you know lungs are inflated anyway. You have to observe for chest expansion. Right? If the heart rate does not respond, there can be 2 reasons, but they can be any idea. So now you have given 5 inflation rates, still the heart rate did not respond. But it can be. Any idea?
Any cardiac cause, madam?
Yes, there is a possibility of having any cardiac cause. That's rare though. Common scenario? One thing can be you have not inflated the lungs, right? If you didn't provide oxygen, heart will not have oxygen and it will not pick up. So first thing is you have to always observe the chest expansion. You have to make sure that you have got a good chest expansion. Suppose the chest expansion is also good, but still the heart is not picking up, means where the baby can be there in that our chart graph. So you have inflated the lungs with good 5 inflation rates. Still the heart is slow. What is the place that baby can be? In our graph? Anyone?
Gasping.
Gasping, usually I told you, when you just even by opening the airway, your heart rate will pick up most of the time. So where the heart rate is very slow, which component in that graph, the heart rate will
Terminal apnea.
Yes, terminal apnea, right? Even if you inflated, if it is the latter part of the terminal apnea, just before death, so there is a whole lot of acid accumulation and completely hypoxic heart, and the myocardium is ill at that point, right? Because of the excessive acid and the carbon dioxide. Then by that time, this metabolic acidosis is extremely settled up. So then you won't be able to recover the heart just by giving oxygen. That's why the latter part of the terminal apnea, you will most of the time have to support the heart as well, right? So once you give the inflation rates, if the heart rate is not picking up, if the color tone breathing not improves, means either you have not inflated the lungs so that you can see, and even if you inflated the lungs, if the heart is low, most of the time it can be towards the latter part of terminal apnea, right? Got it? So then you will have to support the heart well. So how would you differentiate these two instances? When you give 5 inflation rates, still the heart is not picking up. How would you differentiate these two? Whether the heart needs support or whether the lung is not expanded.
From the chest movements.
Yes, good. Right? If you, while giving the inflation rates, if you had good chest expansion, that means you know the lungs should have been well aerated and inflated. But then, if not picking up, that is more likely to be due to terminal apnea. But if you didn't achieve chest expansion, anyway you have to correct the airway maneuvers and open the airway and give the inflation rates again. Right, I hope you understood. Okay. Right. If the lungs are being inflated, then the chest will move with each ventilation. You will see the chest expansion. Right. Mask inflation is nearly always effective. I told you about 95% of babies whom help is called will recover within a minute or two with just the airway opening maneuvers. Once they are enters the lungs. Right. If the chest is not moving, the lungs are not being inflated, then again airway breathing you have to check, and position you have to correct it. Your airway maneuvers you have to correct it first. Failing that, you can look for secretions, right? Even if you think that your technique is very good, you have opened the airway, still the lungs are not getting inflated, you might have to look under direct vision and relieve any obstructions if there are any, like secretions or meconium. That's why I told you at the beginning, no sucking. Always you have to try with inflation rates, airway maneuvers followed by inflation rates. Failing that, only you might look at the airway. That is also under direct vision with laryngoscope, right? Just you put the laryngoscope in, under direct vision, you look at any obstructions. If they are there with a white bow sucker, you might suck it out, right? So there is a thing called 2-person airway support. We will practice it during our practical session. So the C&E technique of holding the mask, we will practice. So jaw thrust, how to give. So put in the neutral airway, neutral position. And then the jaw thrust, how to give. So how to give the double-handed jaw thrust. And how to give inflation rates using bag and mask. And also the neopuff. This is the thing called neopuff. You might see if it is there during the skill session, right? So oropharyngeal airways, you will have to identify them. Maybe for your skis and all, you might need them. So the inspection and suction, I always told you, it should be direct vision, no blind suctioning. You might damage the oropharyngeal area if you put the sucker tube blindly and suck it out, right? So they are very soft tissues they have. So it should be always under direct vision with a laryngoscope or a tongue depressor. You look at the oropharynx and with a large bow sucker, you suck under direct vision. Right? So particulate airway obstruction is very rare. It can have during thick meconium aspiration, blood, vernix or meconium, but it is rare. Most of the time it's the tongue obstructing the airway. Screaming babies will have an open airway. Floppy babies, you might have to have a look after failing inflation rates. So the heart rate has increased and is now above 100, but the baby is not breathing. This scenario. Now you have given inflation rates 5, heart rate picked up, nice, color also improved with your inflation rates, but the baby is not breathing. When you stop giving breaths, baby doesn't breathe. Now what are you going to do? Chest expansion also you achieved, and you have inflated the lungs. Color tone breathing, heart rate also improves. Not the breathing, color tone, heart rate improves, but there's no breathing. what you have to do next?
Continue ventilatory breaths.
Yes, right. So now you have inflated the lungs, you are happy. Your heart rate also picked up, but baby does not have breathing spontaneously. Then you have to continue with your ventilation breaths. I told you they are short lasting breaths, short breaths, and not like with high pressures. If you now already inflated lungs, if you give high pressure, pneumothorax, right? So you have to always ventilate them with low pressures, short breaths. Like you count it as that one. Initially we count it as 1, 2, 3 release. This one will be squeeze 1, squeeze 2, squeeze 3, squeeze 4, like that, right? So first cycle you give 15 breaths, 15 ventilation breaths at first instance, and again you reassess, right? So now you gave inflation breaths, nicely heart rate picked up and everything is fine, but the baby does not breathe. You continue with ventilation breaths, 15 ventilation breaths. Still the heart rate is not picking up. You have to think of supporting the heart, right? Now you got good chest expansion with your inflation breaths, and ventilation also you can see the chest expansion. And now this color tone breathing also improved, heart rate also improved. Color tone breathing improved, but the heart rate is still low. That means definitely baby is in terminal apnea, right? Then you have to support the heart. So 15 ventilation breaths. After 15 ventilation breaths only, you think of supporting the heart. So that means you have to always correct the airway and breathing in newborns before supporting heart, right? So then you can start chest compressions. You will have to practice how to give chest compressions. So the ratio will be 3 chest compressions to 1 ventilation breath. 3 chest compressions, 1 ventilation breath, right? 1 and 2 and 3 and squeeze 1. 1 and 2 and 3 and squeeze 2. 1 and 2 and 3 and squeeze 3. Like that, squeeze 15 is called 1 cycle, right? Okay. So the chest compressions, chest is moving and ventilation is continuing, but heart rate is still less than 100, right? Not 60, 100. So 3 to 1 ratio, 120 vents. So we'll talk about these things. So 3 to 1, when you calculate for 1 minute, it will be 120 vents per minute, right? So depth, how to give the chest compressions, there are 2 techniques. One is 2-finger method here, shown in right side here. Other one is encircling method, shown in left side. So encircling is the most effective one. You can't have any holes there. You have to encircle the baby with your both hands, and with your thumbs you give 1 and 2 and 3 and squeeze 1. 1 and 2 and 3 and squeeze 2. Like that, right? So this is the most effective way, but you have to have 2 people. Now one has to be there for chest compressions, other person has to take care of the airway. Here, if there is only one person for you to resuscitate, only you are there, then you have to give the breaths, give the cardiac support. So 1 and 2 and 3 and squeeze 1. 1 and 2 and 3 and squeeze 1. Here you might need this 2-finger technique, but it is less effective, right? So the depth of the cardiac compression will be 1/3 of the AP diameter. You know, baby, when you looking from a side, chest, there is a thing called enteroposterior diameter. So 1/3 should go down with your compression. 1/3 of the AP diameter should go down, right? And the site is lower 1/3 of the sternum. So you can see the exact site here. These things you should know, how to tell it in words and how to do it, everything you have to know. So the chest compressions 3 to 1. We give chest compressions in order to move oxygenated blood away from the heart to the lungs for further, and to the coronary arteries. So now the oxygenated, now you are oxygenating the blood because you are providing good ventilation, but the heart doesn't work enough to supply for the coronary arteries. That's why your aim is to do the chest compressions and the push blood towards the coronary arteries. So then the heart will pick up. Right? It's not that far and won't take long. With few chest compressions, usually the heart picks up. So anyway, I told you, you have to start resuscitating term babies on air, telling that if you had to go for cardiac compressions, you have to make the FiO2 100% because you have to give supplemental oxygen. You want to support the heart more, right? So the reassess, has the heart rate improved? If the heart rate with your cardiac compressions also, if it is not getting picked up, then you have to check the airway, chest movement and all these compressions. Again, you have to review it quickly, but you have to get ready with the drugs, right? If all these are good airway opening, good chest expansion you can see, and you are giving effective cardiac compressions, you have to go for drugs if the heart rate is still below 60, right? So then you have to go for adrenaline. I told you the dose, and the dextrose, maybe depending on the blood sugars, but normal saline bolus should come here, right? Most of the time we give a bolus and adrenaline. Adrenaline should always anyway be followed by a normal saline flash, not the bolus, I mean the flash. And then you have to give you can give a new normal saline bolus to expand the volume. And then you can check a blood sugar and correct it appropriately. Failing everything, as a last resort, you might go for bicarbonate. But with effective airway resuscitation, if you had to go for cardiac compressions and cardiac drugs, there is a 85% chance of baby dying, right? So if you had to support the heart with drugs, high risk of mortality, high chance of mortality, right? So then giving bicarbonate might not work. But don't tell bicarbonate at first instance. As for cardiac drugs, don't talk about it even, right? The drugs during resuscitation, what you will need will be normal saline, adrenaline and dextrose, rarely bicarbonate. Right, so now when you give inflation rates, ventilation rates, effective chest compression, if the heart rate is still low, that means that latter part of terminal apnea, you might need drugs. Then you have to put a UVC, right? UVC, you don't have to measure and wait like until the blood comes somewhere 6 centimeters if you can insert. If the blood is coming through the UVC, you can give the adrenaline via that. It should be a sterile procedure during insertion, but you don't calculate it and take X-rays before adrenaline. But your aim is to save the baby's life. You insert this. If there is a free flow of blood coming, you give the adrenaline through this, right? Followed by a flash. So then the post-resuscitation stabilization. So you can reassess. Always the CTBH you have to reassess if they are stable. These things you have to assess before sending the baby to either you might give the baby to the mother or for a high HDU, high dependence unit, or to the ICU, right? Whatever it is, you have to check these things before sending the baby there, right? One is the sensorium, how the baby activity, crying, all these things, and the temperature of the baby, 36.5 to 37.5, which should be normothermia. And oxygenation, you can assess with the saturation monitor. And the perfusion, you have to look for CRFT, but pulse volume you might not feel in newborn babies because they are hypothermic and hypovolemic. You might not feel, but perfusion you can check with CRFT. Over the sternum, you know how to check CRFT, right? And then you have to assess the blood sugar. It should be more than 45. Stops, you can remember it as, right? These things you have to reassess and correct. That is called post-resuscitation stabilization of a baby. And parents and records you can't forget. You have to talk to the parents what happened, what we have done so far, and what is your plan towards the rest of the days, right? And the record keeping is should be very accurate and comprehensive. You can write it as retrospective writing, and with the time you came, how they informed you, How did you go there and what was the initial signs of the baby? And how did you resuscitate? Step by step, you have to document nicely. In times to come, you might have to go for courts, right? Sometimes if you are working in a foreign country, definitely you have to have accurate document record keeping. Right? I told you poor prognosis if there is no heart rate at birth and still absent at 10 minutes. Right? So therapeutic hypothermia, I don't think you have to know at this point. Okay, so any questions? Anything you want to know regarding the things we discussed or anything, any questions you have regarding neonatal resuscitation? So nearly half of the people are not there in the class. Will they be like, how will they get to know the things? Are they going home today?
Yeah, madam, some of them are going home.
So we will be having the session on when? The practical part? This Monday, do you have anything? 20th? Any classes? Asharananda?
Navagi, madam, shall we check and let you know?
Yes, this Monday, just check and let me know.
Yeah,
if
sure,
you
madam.
can do it, like it will be easy.
Yeah, I'll tell her to check.
Just discuss with them and let me know.
Okay, madam.
You have my phone number with you, no? I think or you can put a message. I can. Oh no. How can I? ආශ්චර්ය නේද මට උදේ කතා කරේ. See, can you just pass the message to her?
Yes, madam. Kiana.
Just tell her Monday if we can arrange it. That will be better, right?
Okay, madam. Right.
So, any questions you want to know, you can just drop me a message even, or else we'll discuss later. Okay? During the practical session.
Okay, madam. Thank you.
Okay, madam.
Okay.
Thank you, madam.
Okay.